All right. Hello, everybody. And I am so excited to have you all here with me today. And I'll just kick things off by saying if you use the GI map in your practice, but if you've ever felt maybe a little overwhelmed by looking at that, I mean, it is a dense report, right? Chock full of value. That being said, sometimes, you look at that report and you're not completely sure on where to start. Um, Definitely, this conversation is for you. So I am so looking forward to it. I am joined by my special guest, Dr. Amy Rolfsen, and she is a clinical consultant with Diagnostic Solutions Laboratory, otherwise known as DSL. And Amy works directly with clinicians every single day, helping them to interpret GI map results with clarity, confidence, and clinical intention. And today we are going to be talking about how high performing practitioners move beyond protocol chasing and instead use pattern recognition, prioritization, and stepwise care planning to get better patient outcomes. And this is all without adding more complexity to your already busy workflow. So, Amy, I am so delighted to have you here with me today, and I can't wait to dig into this topic.
I'm
Welcome.
excited to be here. Thank you for having me, and thanks everyone for being here. So, I work with Diagnostic Solutions Lab. I'm part of a clinical team. We are the education team where we put out our online education, our resources, but we also do one-on-one clinical consultations. Anytime you order a test, whether it be directly through us, through something like Avexia or Rupa Health, you are eligible to consult with us, and we are here to calm you around what might be overwhelming results, to help bring more clinical value. And we really want you to do well. We want you to do well and bring your patient's entire case to us and get the best clinical value possible so your patient can do better. And so
I
I'm
love
here
it.
today to, talk about some common questions and help guide you in making it easier.
I love it. Okay. So, all right. And by the way, what is your background in terms of like the other things that you're doing in
The other
addition
things that I'm doing,
to
I'm a naturopathic doctor. I'm based out of British Columbia, Canada. I have a private practice here, and I work also in the online space with female hormone transitions mostly. So that is perimenopause, menopause, and also puberty. So that's my area of special interest. But then also in the microbiome, I do one-on-one consultations in my practice too with people who want to go over their test results, whether it be GI map or putting it all together to find direction forward, or clinicians who want some extra help. But most of my heart is with DSL and working on research and education and speaking engagement. So it is such a wonderful company to work with. And the tests, we have
I
a whole
love
lineup
their
of tests.
tests.
Yeah, so it's not just the GI map. We have a whole lineup of tests that are amazing, but most people find us through the GI map. A lot of the general public is looking
Okay.
for the test. It is one of the, if not the leading stool test in North America, and that's for a reason.
Okay. And we're going to focus on that particular test today, but just
Hmm.
for our information, if you don't mind, what are maybe your top three tests at
Yeah, great
DSL?
question. Okay, so this is the GI map. I'd say it's top two. Probably my number one. It's the
Okay.
test I put most of my mind into. My second favorite is the OAP, which is a next generation organic acid panel. So that's a urine only test.
Okay.
And then it's got a very similar test, the Omics, the OMX, which is pronounced Omics, which is urine and serum. So I find a lot of practitioners, whether they don't have access to phlebotomy to draw blood, or if they have a patient base that is more anxious or pediatric, or say ADHD, where booking an appointment to get a blood draw is an obstacle, I find the urine only test is a really nice option where, okay, this is one sample, it's very simple, you pee in a cup, send it off.
Yeah.
That is a test that gives you so much metabolic data for people who are, say, struggling to lose weight or feeling low energy, mood changes.
Okay.
And it's not as well understood as a gut test, how that might help people. But those two are my top two tests. We also have some very interesting tests. What else have we got? We've got an amazing serum cytokine test. So looking for inflammation, that is a very niche test. And then we've got a DNA test, which is really well done. We've got food sensitivity and environmental allergies, and a couple of other tests that are not
Okay.
coming to the top of
Okay.
my head.
That's great.
Yeah.
Okay.
Yeah, it's a great list.
Um, really comprehensive.
Hmm.
Okay, well, let's talk a little bit about, what happens when a practitioner opens a DSL account
Hmm.
and maybe kind of go in specifically when they run their test, right? They do their first GI map, they get that report back. And they are like, oh my gosh, there's so much here. Where do I even begin? We want them to
Exactly.
feel confident in delivering those results back to their client or patient. So what are your thoughts on, how we can help them to become confident and not overwhelmed?
Yeah, so first I would say running this test, I have been interpreting this test for probably close to 8 or 9 years, working with the company for seven. And I can count on maybe three fingers the amount of times I've seen a test that did not have a lot of clinically actionable results. So a test that did, every test I see basically changes the clinical trajectory.
Right.
And even when it doesn't, those maybe three times, that gives you information saying, wow, this gut actually looks perfect. Maybe it is the mycotoxins
Okay.
we're looking at. So that is direction too. But this test will add value to your patient's care and you'll be able to personalize it, especially if you use our resources, because not everyone should be expected to memorize the microbiome and where each organism lives and what it likes in terms of acidity. That is our job. We are the people that can help you, and booking a clinical consult will really help. I would say also running a test on yourself and your family members is a great place to start. Many clinicians will find that the messiest test they ever look at is their own. I see that over and over again. They look at their
Really?
patients and they're okay. And then you run your own test and you see, wow, I have no immune system and I sure look burnt out. Exactly. And then, so what I get most frequently, I get a lot of people calling in overwhelmed, and I see it as my role as a consultant and an educator to help ground people. So if you feel overwhelmed with a test, don't lose sleep over it. Call us. Call us. Our consults are usually booked a few weeks out, but we are here to get you better clinical relevance. And we see tests day in and day out, and we see patterns. We're really good at pattern recognition, and you will become good at pattern recognition too. We have a lot of online resources for that. But I get people that call in and they've got a patient in front of them who's feeling unwell, and then they get the test results back, and there are findings on the test results. And they're findings that are scaring the clinician. And so they call in and they say, oh no, there's things on the test. What do I do? And I say, well, isn't that the ideal? Is to have a patient who's feeling unwell and to have a test come back with results when maybe they've been to their medical providers and had lab test after lab test that say they're normal and yet they don't feel like themselves, or they feel unwell and they're labeled as perfect specimens of health, and then you finally have a
Right.
test with results. And yes, it's overwhelming, but that is the dream, is to find positive results on a test, positive results that are manageable, and then we just prioritize it. So we take a deep breath, take a step back, and ground yourself in your patient's clinical history. So we want to know, how is your patient? What's going on with them? And how can we match these results to what's going on with them to get them the best results and to build them a protocol that is not overwhelming. We want to build them a protocol that they can follow, that they can buy into, and also communicating the results and the plan with your patient. So a lot of skill sets here. And if you come to your appointment knowing what's going on with your patient and ready to learn, we'll be here to help. And I get another
Okay.
subset of people that call in and they say, I was expecting more. Why is there nothing on this test? And I look at the test usually and I think, are we even looking at the same test? Because
Really?
the things that I see as deeply significant are not always what people look for. In our clinical practices, especially lately, we're looking for overgrowth, we're looking for pathogens, we're looking for red hot markers, really high immune system, things like that. And if we don't see that, we're almost disappointed. But I see so much clinical value in things like low normal flora, so the commensal organism section, low immunity, low digestion. And even if you see just low elastase, low digestive enzymes, that can affect a person's entire body, their energy, their ability to repair, their immune system, everything.
Okay.
Hmm.
Well, it's interesting what you mentioned. I actually know someone who um went to all kinds of many specialists
Hmm.
along the way, immune specialists, like at like major teaching hospitals, really trying to identify, like, is there an immune deficiency of some kind or some sort happening here? Because the person just was getting sick literally all the time, like
Mhm.
coming down with a cold, I would say, like constantly felt like they were, like chills, feet, like it was really bad.
Mhm.
All, like doctor after doctor in this case, they're just looking at like your regular blood test, right? So nothing against that, but basically everything was coming back normal. So
Mhm.
anyway, long and short is this person did end up doing a GI map, and it was a complete utter train wreck. Okay? So the reason I share that story is it gave direction, right? It was like, okay, so we know something is dragging down the immune system big time here. And as it
Mhm.
turns out, it was really horrible mold toxicity,
Mhm.
SIRS, right? The
Mhm.
chronic inflammatory response syndrome, like really, really, really bad.
Mhm.
So just kind of a little example of how, a lot of your traditional labs were coming back looking pretty good,
Mhm.
and then we
That's a
did the
sign of good
GI
health
map.
too, right? Good baseline health if you can keep your
Sure.
blood markers looking normal.
Right.
Mhm.
And then, but ran that GI map and it was like, whoa, yeah, things
Yeah,
were, yeah, pretty much a train wreck. So, I know the person was actually really happy to finally have some answers,
it's very validating.
It was validating for this person
Mhm.
because this person knew that something wasn't quite right, and yet, just could not get to the bottom of it. So
Mhm.
really was so, so, so helpful.
Great.
Um, okay, let's kind of go back to those results. So how do you go about turning, rather complex, usually it's pretty, it's a great report, right? You get so much information.
It's dense.
It's very dense. So what
Mhm.
do we do? Like, what can you share, us, like, in how do we interpret those results
Mhm.
and into a clear step-by-step plan that's, I would say, manageable, not
Mhm.
only for practitioner, but also for the patient or the
Mhm.
client. So what are your thoughts on that? Because, it can be a
Absolutely.
lot.
It can be a lot. And if you are just looking at the individual findings on the test and giving a plan for this and a plan for that and a plan for
Mhm.
that, you're going to end up with 85 supplements and total overwhelm and no room for food, right? You're just taking pills all day long.
Yep,
So
yep.
I think as a new clinician, once you've run the test on you and your family, great, and you're interpreting that, calling in, and of course letting us help you, but pattern recognition is going to be really important, but never forgetting about your patient's clinical history. How are they presenting?
Okay.
And what patterns are we seeing on GI map that might explain why they're feeling the way they are? So often, especially when we're new in lab testing or in practice, we'll meet a patient, we'll run the test, and they'll think, okay, good, the test will do the job. I don't have to remember anything. Or it comes back and you just get so blinded by the results and you think, oh my gosh, we need to treat this bright red finding. So always just take a breath, ground yourself on that, what is going on with your patient? How are they feeling? Does this fit with their clinical history? And if it doesn't seem like it does, call us and we'll help you. We'll help you find it in terms of clinical history. But I always start with the basics. So the questions I'm asking myself, what can we identify in our patients, either their GI tract, their clinical history, their environment, their diet, that might be obstacles to them having good health and having a good equilibrium of health, because our body does want to fall into equilibrium. And if we get everything in place and we remove the obstacles, some of which are adaptable, some are modifiable and some are not. But what can we do to get them closer to a place where their body can repair itself? So I'm always looking through the test. I, of course, start at page one, which is your pathogens. Look at the numbers, don't spin out. Then we look through and we think, okay, is there H. pylori? Do we need to do something? Looking through commensal organisms, the good guys, looking through the opportunists. And then you finally get to the intestinal health markers. And that is the most dense section of the test. And
Okay.
that's what's going to position everything else. So we're looking to see, Okay, so looking through the test, we saw a lot of findings. How is digestion? How is immunity? Because digestion and immunity, if they're weak, or even if immune system is fired up, it's fired up for a reason. It's doing the best job it can to try to clear organisms potentially, or in a response to food sensitivities and gut permeability. So looking at those markers, and of course, the markers for inflammation and blood, do we have anything to be more concerned with on a medical level? Do we need to refer? And you can
Okay.
refer and still manage your patients, but if you see overgrowth of bacteria, of parasites, we want to think, okay, why are they there? What has allowed them to be there? It's not usually, although sometimes it's not usually a chronic exposure, like you're drinking stream water all the time and you're getting Giardia daily. It's, if a whole family has the same exposures, why does this one person have an organism? So we look at digestion and immunity, and that's where I like to start. We don't have big markers for nervous system, but I would say the three things: digestion, immune, and nervous system.
Okay.
Get those settled first. If you don't know where to start on those. And digestive enzymes, giving an enzyme, that's not a band-aid. That is a way to help your patient break down nutrients, but I consider that to be part of my antimicrobial protocol. To give an enzyme, they can break down cell membranes, but they also help you digest and absorb your nutrients. And often we have overgrowth because we're not efficiently digesting our food and we're making the wrong food choices and we're maybe eating under stress and things like that. So if we can help people just digest better, that could be everything, but it is a strong addition or foundation even to an antimicrobial protocol. And then seeing if there is low or high secretory IgA. So those are where I
Oh,
go first is how is digestion? How are the antibodies? How's the immune system? We are looking at the other markers in the intestinal health, but those are the ones where often I'll give people that foundation of maybe an immunoglobulin because they should be able to, over time, get their own immune system back in the gut, but that takes a lot of work. And so I think it's really beneficial often to give that extra antibody support. Maybe we're giving a probiotic, but I love the bovine immunoglobulins. And often at the first visit, I will just start with a digestive enzyme and immunoglobulin and say, hey,
okay.
are you drinking water? How's your sleep? Are you chewing your food? And if you're not chewing your food, you're missing a big step of
Okay.
breakdown. Yeah, so keeping it really simple. And you can see any organism on the test. And even if they really well match your patient's symptoms, if their symptoms are chronic, it's not going to be wrong to start with a foundation of digestion and immunity.
And do you is in terms of, I guess, your philosophy,
Mhm.
um are these long-term therapies like digestive enzymes and, maybe the immunoglobulins, or
Hmm.
do we retest and see it, like give me your thoughts on how long do we stay on these therapies? And
Yeah, that's a
do
great
we stay on
question.
them, indefinitely, like, potentially the digestive enzyme?
And that really depends on the patient. And I think it really solidifies our role as practitioners. And I think a huge part of our practice success and our patients' perception of success and satisfaction is setting their expectations.
Right.
So you have a patient who has, in their mind, they've been unwell since last year when they, maybe had a histamine event. And then you ask them thoughtful questions and you realize that, okay, it's probably been 20 years since you were actually well, right? So
Oh,
we've got this cascade of events, and I think we all work in this population where people just are not feeling like themselves, and then suddenly there's an event that puts them out of commission where they can't show up to their daily lives in the same way that they had before. But the process of becoming unwell and becoming more and more stressed and their body not necessarily breaking down but kind of losing its center has been a longer process, and so it can be a longer process coming out too. Not that we need to necessarily remind our patients, but I think looking at that, taking everything into consideration and thinking, okay, if we brought this patient's GI tract back to the best it can be, will they be able to get that signaling to the pancreas? Can they produce their own enzymes? Um, I think in the short run, it's reasonable to support with immunoglobulins and enzymes, and then some people will get that function back. So if you bring your small intestine health back, you'll be able to better signal to the pancreas that, hey, it's time to put out some enzymes. Where the pancreas might just be waiting. It's just hanging out. It's putting out some enzymes, but maybe not getting the signaling it needs. But that signaling is reliant on things like minerals and proteins and nutrients that you are required to absorb and digest and assimilate. So if we can get better nutrients in, maybe making some dietary shifts, some lifestyle and nervous system shifts, we might be in a better state to get that enzyme production going. And then,
And then,
mhm,
oh, go ahead, go ahead.
I was going to say sometimes that stomach acid is one of the last things to come back. It can be really
Okay.
tricky. So for some people, it may be long-term management to be on enzymes
Yeah.
or immunoglobulins. Say they've got a true IgA deficiency, and that just might be their reality that they're on immunoglobulins, and some people have had low immunity since childhood, or maybe somebody with cystic fibrosis will always have a bit of lower elastase production, things like that. So just looking at your patient's history and thinking, okay, yeah, if we correct what we can correct and modify what is modifiable, what might be left over. And so I don't always give clear answers to people when they ask how long is it going to be. I'd say,
Okay.
I don't know, let's see how things go.
Would you
But
discontinue? Oh, sorry.
that's okay,
Finish
Leslie.
the line. Would you discontinue supplements and then retest at a certain point to
Mhm.
evaluate whether or not, the body has kind of recalibrated and is doing what
That's
it's
a great
supposed to
question.
do?
Yeah, I think that depends, and the whole retesting question is a big one. So,
Okay.
what do we want to do? What do we want to see on retest? And I get that question a lot. Now, I always keep people on any medications, any necessary medications, even if
Sure.
they are on long-term antibiotics that they cannot come off of. They're still eligible to run the test.
Okay.
Or if they're on antihistamines or steroids, things like that, you can run the test. We'll just interpret it in a bit of a different light. Now, the question of probiotics, I keep people on their probiotics generally. It's not going to make a big difference in terms of the numbers on the test if you keep them on a moderate dose. If they're on something like a 300 billion lactobacillus, it might show up higher. But below that in kind of the 25 to 50 billion range, it doesn't make a huge difference.
Okay.
Elastase 1, our measure for pancreatic enzyme output, you won't find that in an oral enzyme. So that is not necessary to remove. But
Okay.
what you might see changing if you keep the enzyme in place is the fat absorption. So steatocrit, the marker of fecal fat, if that's a moderate level, like 6% or 8%, and you start a digestive enzyme, that might be enough. The lipase in there might be enough to help digest fats a little bit more so that steatocrit looks better while you're on the enzyme, but the elastase won't change much.
Oh, that's
So
so
you can keep
interesting.
people on their enzyme, and then if you want to see, say you put them on a fat absorption support with bile and lipase, and you want to see how are they doing without that, then you remove it. I'd say 7 day washout should be fine. But there's another situation where you might want to see how well managed they are on your fat absorption support, and then you keep them on. So it's a loaded question with a loaded
Okay, yeah.
answer.
It
Yeah.
takes some thought. Okay.
Mhm.
All right, I want to ask you about um I guess how do we ensure we're getting a really good sample? Because obviously it's not homogenous, right? So, can you speak to that in terms of, I guess it would be the sample collection and just doing the best we can do to, yeah, just so we get a good sample.
Absolutely. And nobody likes the moment they're stool sampling. You're sampling your own or you're sampling your children. You've got it out there. And let's be honest, water does us a lot of favors for the smell of that sample. It's not the most pleasant moment of your day. And I would say don't rush it.
Okay.
So there is a lot of evidence that your microbiome can shift before versus after meals. So in a fasted and a fed state, sometimes your organisms will be different
Okay.
with a formed solid bowel movement. You want to test a little bit from the head end, from the tail end, from the inside, from the outside, and just get
Okay.
as many little core samples as you can. You may see vegetable fibers, just really get in there. If you see different textures, get a little bit of every kind of ecosystem you can see in there. And then when we've got a looser bowel movement, you may see that some parts are loose and some parts are not loose. Just don't rush this moment. You don't need to get a blender, although you may. If you, if you choose to get a blender, you can have a dedicated blender. Don't use it again for smoothies. But you should get a decent representation. Say you have 1 to 2 bowel
Wasn't
movements a day.
expecting that. Sorry. Oh my God, I was not expecting that. Okay. That is
Well,
very
I mean, the questions I
insightful.
get asked on a daily basis, and
Yeah.
the
Oh, that's so
The
funny.
photos I used to get sent on a daily basis that I've now put up boundaries around.
Oh
At
my
least
gosh.
at least
That
a
is
warning in the email subject, right? Yeah, spoiler, it's probably not a worm, but thank you.
oh God, oh God, this is so funny.
But yeah, getting a good, not homogeneous sample, but getting a good amount of core samples, and
Okay.
then you've got that liquid in the container and you fill it up. It doesn't take a lot to fill that up. So make sure you're sampling all around. And then in
Okay.
terms of what day to sample, sometimes you've got patients with variable stools.
Yeah.
Or another situation I see a lot, you send away a patient with maybe GI symptoms or chronic symptoms and you don't see them for 6 months. And then you find out that they had gastroenteritis and they thought, oh, weird poops, let's test today. That's not the day to test. You
Okay.
want to be counseling your patient that, say they're a person with IBS or something like that, that fluctuates from day to day. And some days they have good bowel movements and some days they're a little weird. You want to find that weird day that is their normal abnormal, if that makes
Okay.
sense. So the
Yeah.
abnormalist bowel movement that is part of their normal routine that they're used to.
Okay.
And if that happens on a weekly basis, great. If you have to wait 6 months for that to happen, say they have a bout of something and we don't know what and we want to find out what every 6 months, don't wait. We want to see what their gut is doing now. And you might just find that they've got really low immunity. And that's a
Okay.
very worthwhile finding. You might not find out if there is an organism that cycles in every 6 months, but I find in clinical practice, if you wait for that moment, you'll never get it.
Okay.
Yeah.
That makes really, really good sense. So, especially if there is something chronic going on,
Mm.
yeah, you
Get
don't,
get a funky day.
yeah,
And then
get a funky day.
yeah,
Okay.
unless your funky day is truly watery stools, unless that's your daily and unless you want to
Okay.
see, okay, do I have, I don't know, but thinking of the, salmonella every single day, you
Okay.
probably don't. But the watery sample might be a bit dilute. Yeah.
Gotcha.
Mhm.
Okay. That I think our listeners are going to find that extremely
They'll
helpful.
figure it out. Yeah.
Yeah. Okay. All right. And is there anything else we want to add in terms of follow-up testing?
For
I
follow-up
know we touched
testing,
on that a little bit, but just want to make
yeah,
sure we close that loop.
yeah, for timeline, often what we see, we'll see two major patterns on the test. We'll see the need to reduce organisms, or we may want to do what's, an eradication protocol, something for bacterial dysbiosis. That's usually going to be about a 2 month protocol. And then you want to finish your antimicrobials or antibiotics and wait a month and retest. So in those cases, you're looking at maybe 4 month kind of full turnaround from original test to second test. And then if what you see is a deep deficiency, you've got no normal flora or low normal flora, low commensals, low digestion, low immunity, I would retest more like the 9 month mark. We're going to do that, deep and important but unglamorous work of rebuilding. We're eating really healthy, we're sleeping really well, we're taking all the gut repair nutrients, retest in 6 to 9 months. And if your
Okay.
patient is feeling like $1 million, it's you might want to look and you might not. You might want to focus on something else because there are only three reasons where I would medically need to retest. And in terms of curiosity, I want to retest every time. So the reasons I would absolutely need to retest in my personal practice would be pathogens. If you see something on the pathogen page, if you see blood, or if you see calprotectin, our inflammatory marker, those are the ones where we want to always retest. Yeah, always retest those at some point in the next couple of months,
Okay.
and think about referral.
And what are your thoughts around, okay, this is probably a really big topic that we could
Oh,
do an entire talk on.
and we
Um,
can.
and I would love to because I think
Okay.
it would be amazing. And I think it would be so helpful for our audience. But let's just talk a little bit about H. pylori, shall we? Because I hear, some concern about, the level of sensitivity and specificity when it comes to H. pylori. And, I think for some practitioners it can be like, kind of a OMG moment, right? Where you're like, oh my gosh, what do what are your thoughts on that? Because my understanding is this test is very sensitive and very specific. So you're gonna pick it
Mhm.
up, is
It,
at least
it,
how I interpret it. But you tell me.
It is extremely sensitive and extremely specific. So the
Okay.
quantitative PCR, the technology we're using, we're picking up H. pylori DNA in the stool. Now you
Okay.
hear people saying, okay, that's a past infection, but we're actually only picking up whole cell DNA. And so to think about, I'm not going to bring you into GI immunology, but whole cells, whole dead cells do not survive in the GI tract for any amount of time. You know, they're cleared out very efficiently, and you'll know if your immune system is not making that happen. So this is a current or, you know, at least a yesterday population, but probably a today population too.
Okay.
And yes, the test is very exquisitely sensitive, and we present numbers that are sometimes in range. Of course, we're looking at scientific notation, so you'll see maybe your patient has 100 organisms per gram. That's 1E2. Maybe they have 10,000 organisms per gram, and I would treat those very differently. But it is an invitation for a deeper interpretation. And that doesn't always land well when we're used to black and white answers, right? Maybe we're used to conventional testing. If your background is in hospital care, and then suddenly you've got this area for nuance. And I like to think of it as the clinical sandbox, where it's an invitation to play around. Um, what I find grounding and helpful about H. pylori is knowing that, and this may not be helpful to everyone to know, most people pick up H. pylori in the first 5 years of life, and most people pick it up in the first year of life. Most humans carry H. pylori,
Okay.
and so you'll get a test and it may be positive for H. pylori. Maybe it's high positive, maybe it's within range. And what I like to just remember is that your patient had H. pylori a month ago and they didn't have gastric cancer. Or, presumably most of them did not. They had H. pylori 5 years ago, they had H. pylori 10 years ago. So it's not urgent. And we keep it, if we don't decide to treat H. pylori on day one or month one, we keep it in our future plan and we can think, okay, H. pylori is there. Now, even finding it within range is an invitation to consider treatment because we found an organism that is hard to find. And classic testing methodology is less sensitive. So sometimes you'll have people who have been looking for years. Say they're 55, they have true ulcers, and they've had scopes with biopsy and they've been negative. And then you run a test and you find a moderate level of H. pylori. I think that's significant and that is a gift to be able to find it. And in those cases, I would address it. Would I treat with antibiotics? Not every time. But then you see somebody whose main symptom is maybe something like anemia or low energy, and you see H. pylori out of range. That could be a reason for low iron, and there could be other reasons. So I see it and I think we don't always need to do something right away. There is a lot of nuance to the interpretation, and I think that can be off-putting for people if when you're used to those black and white answers and when you dig into the research and the research is based on less sensitive testing and you see these answers saying, okay, if you find it, treat it. And that's the common thought process around this organism, but knowing that most people carry it and that for most people the net effect may be a decrease in stomach acid, and so weaker digestion, maybe more susceptibility to organism growth. So you'll see people like your chronic recurrent SIBO or dysbiosis, your chronic parasites, that might be encouraged by an H. pylori population. So it may be valuable to consider it, but it's not an emergency. Most of the time, it's not an emergency. And then another thing we'll see often is a change in our ability to absorb minerals and proteins. So there's this whole functional scale of symptoms that might be associated with H. pylori that we may want to consider addressing it. But I do think there can be a risk of overtreatment if you just see red on the test and then give antibiotics. That is intense. And I think there's that thought process too that, oh no, there's one more thing that's almost always high that complicates treatment plans. So you don't always need to treat it right off the bat. You keep it in your future plan. And another thing, often I bring it back to the patient. So we come and we discuss the test report, and I say, okay, well, reviewing your symptoms and reviewing the test, let's go through the findings. Now, H. pylori, I see that it's here. I see that it's a high, maybe it's a high normal. And because you don't have upper GI symptoms of reflux, burning, things like that, let's leave this and we'll think about it later. And then that's calming for me. It's calming for the patient. You can think about it later, and it just presenting it as an expectation that maybe we'll come back to it, and maybe this is a blocker to longer term remission from your gut symptoms. That's calming. But there's a lot of patients who at that point will come and they'll say, "Oh, wait, I do have reflux. I have reflux every day, and I didn't think it was abnormal because I've been told for 25 years that this is normal and expected, and reflux is a normal human condition." So having that conversation in that way, just kind of calm, gentle, saying, "Hey, I see this organism. It may affect you in these ways. Let's just leave it, take a breath." And there's a lot of ways you can address it. So it's a lot. It's a lot for practitioners to come up to something new, but I think it should be seen more as an invitation and a gift and a really, really sensitive test. So, yeah.
I like that. And I hope that we can have a future conversation and really dig in into
Yeah,
that
that'd be fun.
concept. Okay, just really a couple more quick questions. So I just want to make sure that our practitioners walk away with some good, good sense of clarity in
Mhm.
terms of, how we can help them make, I guess, the interpretation component a very
Mhm.
smooth and hopefully a repeatable type of workflow. Do you have anything else that you would like to share in that regard?
I would say use our resources and use our clinical
Okay.
team. Get in the habit more of pattern recognition than of single organism obsession, right? You look in and you think, okay, why are all the normal flora overgrown? Why are both phyla overgrown? And you think, okay, what does it mean about the GI environment that they might be like that? And we're here to help. So if I send you home with one message, it's that you can run this test on everybody, literally anybody. You'll get great results, and we can help you interpret those results. So don't feel like it's on you to know everything. Um, I think a lot of people struggle to talk about the test with their patients. I would say when you're looking at a patient and you know what they're going through, make the test about them. Don't necessarily say, "Oh my gosh, we can find parasites, we can find H. pylori, we can find low digestion." That's not what they want to
Okay.
hear. They say, if you say, I treat a lot of women in midlife who just aren't really feeling like themselves anymore and their digestive system is often disrupted. This is a test that can help us get to the bottom of what might specifically be going on for you,
Okay.
and then you get the test back and go from there. But make it about them and just feel confident that you will get great results with this test. You will, and
Okay.
we'll help you turn those results into, we can't exactly give treatment plans, but we can give a lot of direction and insight because we see so many tests. We see so many before and afters. So come having looked at our online resources, we have a ton, and it can get easier. And it does get easier. You'll get really used to it, and we will help guide you through how to look at a test. So look at the whole test before you make big decisions.
Okay.
Mhm.
Great. And what would be a next good step for our practitioners who, maybe we've piqued their interest, either
Mhm.
probably two camps, right? The practitioner who maybe has never run a GI map but
Mhm.
is now interested in doing so. And then we've also got our practitioners who, maybe they have an account, um, potentially they've run a test maybe on themselves or a patient or a family member. What would you say would be a good next step?
Great question. So for the people who have never run the test, open an account. If
Okay.
you have an account directly through DSL, there are some benefits in terms of discounted tests for friends and family, not friends and family, sorry, direct family members and clinic staff members. So the other, your receptionist, the doctors in your clinic. It's a great discount, any test, anytime. And so that's a great way to get started on GI Maps. So you've got people with metabolic stuff going on, try out the OAP. It's an amazing test. And then book your consult. But for workflow, you're going to want to know, and you're going to want to have a system for when your patient sends in the test, how do they let your office know? Because it's when the test is received in the lab is when you want to book your consultation. Because we're booked about 3 weeks out, 2 to 3 weeks out at any given time, and the turnaround of the test is about 2 to 2.5 weeks. You really want to know somebody in your clinic will be getting an email, at least if you have a DSL account. I'm not sure what Rupa and Avexia do, but you want to get that email and turn that into a clinical consult. So the trigger in your clinical systems where when you get that notification, book a consult because we are really going to help you. It's what we want. We want to get you good clinical value, but we're also booked way out. well, not way out, but about 2, 3 weeks out, right? We want you to have that test back and not miss a beat. We want to give you that value and get you back with your client because time does add up. And if you have to wait an extra 2 weeks, that can be really frustrating.
Mhm. Okay.
So I would say run it on your friends and family or your clinic and family, but yeah, run it on your friends and run it on yourself. You'll get the most invested in your family's tests, right? It's so interesting. And we get a lot of people calling in. So no shame in the game. Run it on yourself and your family. And then if you've already done that, look at your patient population and say, who, whether the center of their case is GI, whose case do you think is being held back by something going on in their gut? You'll have an intuition of who it might be. So your population might not even be at all gut related, but you're gonna find interesting results. I consult with people who run migraine clinics and they run the test on everybody. Dementia clinics, they're running the test in Parkinson's and not just neurological health, but menopause clinics, pain clinics, everybody's running the test and getting very cool results because what happens in the gut does not stay in the gut. It like your patient or your friend with SIRS and
Yeah.
mold toxicity, that affects every tissue of the body.
Right.
So just be confident that you can run this on people and choose a patient who is willing to look a bit deeper, run the test on them and get comfy. Just
Okay.
watch our videos, call in. Yeah, we're here for
Yeah,
it.
and I know that your organization, your company provides amazing support. Case in point,
We're trying. We're
having
trying.
you here with us today to help
Mhm.
educate everybody on the testing process. So and the interpretation most importantly. All
Mhm.
right, any final words of wisdom as we start to wrap up?
Oh my goodness. Great question. I would just say don't panic. Don't
Okay.
panic. Just confidently run the test. Know that we've got your back. We've got the resources. I would say the top two resources are going to be a clinical consult and our interpretive guide. And then if you
Okay.
find something oddball on your test, we've probably got a video on that. And we'll talk you
Okay.
through it. Watch those ahead of time, but just run the tests and see what
Could
happens.
you comment just really
Mhm.
briefly? You mentioned the interpretive guide. I know I
Yeah,
have a hard copy of that.
I bet
It's
it's scribbled
amazing.
on.
Yeah, I love that thing so
Yeah,
much. And I refer to it, kind of often because it is really a great piece. Where can our practitioners here with us today, where can they get that?
great question. So that is on our website,
Okay.
which is diagnosticsolutionsLab.com.
Okay.
How I find it on the fly, I just type in to Google GI map interpretive guide and it pops up in PDF, top 1 to 3 hits. You'll find it. Our website does have navigation. It's under the clinician resources, I think is what it's called. You'll
Okay.
find a lot of things, including signing up for the DSL Online Academy. But fastest way to find that, just Google it. It's
Okay.
there. It's a PDF that's what, 70 pages long? It's
It
massive.
it
And
is. It
it's
is so good.
it's very research dense. And then when you look through that, so you've maybe got a couple of days between receiving your test and your consult, if you or your clinic staff members booked at the right time, you've got a couple of days. Go obsess. Don't lose sleep over your patient's results. They're okay. They're
Yeah.
okay. And then come in with all your questions because we're here to answer high level questions. We want you to have the information and have weird questions, very specific questions, and we'll say, okay, yeah, I'm here for that. And sometimes the things that I see as priorities on the test are not what people come in panicking over. So I do see my job as calming, grounding, and normalizing because it's a gift to find things, positive findings on a test. If it looks weird, and it looks weird in 7 different ways. That is 7 different ways how you can get your patients or clients feeling better, and you can deeply personalize their test results.
I love that. Such a kind of a shift in mindset instead of freaking out and panicking. Let's look at it as a gift to be,
Mhm.
given this insight and information that we otherwise, honestly, I would say in many cases we'd still be left guessing.
Agreed. And I
So,
do think advanced testing is a gift. And if you feel like you're selling it to people, you're not, you're offering access. You're offering access
right.
to advanced insights. And it's like Aladdin and the magic lamp, right? You've got magical answers just right inside. You don't know what they're going to be. And I don't I'm too embarrassed to admit how many times I've been completely wrong about what I'm going to see on GI map. It comes back. I'm not embarrassed about that, actually. I think it's great. That's why we run testing, because every time I guess, I'm wrong. Same with running hormone testing, things like that. It's like, wow, that's not what I was expecting. And it's such a pleasant surprise.
Yeah. To be
Yeah.
given the data,
To be
which
given the
is
data and
amazing.
knowing what to do with it.
Yes.
Hmm.
All right. Well, I want to thank you, Dr. Amy, so very much. You were incredibly generous with your time today, truly.
Of course.
And I loved every minute of it. And I sincerely hope we can do this again.
I hope so
If
too.
you're if
Thanks for
you're
having
if
me.
you're up for that, we'll
Hmm.
dive into maybe another aspect of maybe H. pylori, maybe one of the other tests that
Yep.
that you're offering. So, anyway, I want to thank everyone for joining us today. Hope you got a ton of value. I know I did. And again, thank you to Dr. Amy for your willingness to jump on this call with us
Mhm.
today and share your wisdom. Really appreciate it.
Perfect.
All right,
Okay, thanks for
everybody,
having
take
me.
care. Have a great rest of your day and see you next time.